Hello, dear students. I am Dr. Mushfig Orujov, the Associate Professor of Department of Pathological Anatomy, Azerbaijan Medical University. Today we have a lecture about the dental diseases, such as the caries, non-caries change. So here you see the plan after lecture, the dental plaque, dental stone, dental caries, pulpitis, and periodontitis. First, I would like to remember you some short clinical morphology and the histology, as well as the teeth. As you know, that the teeth are located in the corresponding dental alveoli of the mandible that we call the lower jaw and the maxillar upper jaw. And the total number of the teeth in the adults reach 32. So there are 8 teeth on each half of the lower and upper jaw, respectively. 2 incisor, 1 canine tooth, 2 premolar, and 3 molar teeth. In the external appearance on the longitudinal direction, each tooth consists of 3 parts: the crown, here you see the neck, and the root that directly located inside of the bony structure. And you know from the histology course that there are 2 types of the dental tissue, the hard tissues that include the dentine, enamel, and cementum, and the soft tissue, the pulp, gingiva, and periodontium. So now we start a discussion about the dental diseases. The dental plaque, this accumulation and fixation of soft, viscous allium masses on the tooth. Such allium masses are mucous and food remnants, microbes, and products of their metabolism that destroyed epithelial cells, leukocytes, etc. Microorganisms, especially streptococci, which find favorable condition for live activity in the dental plaque, multiply rapidly. The dental plaque is more common on unclean teeth or on contact surfaces of teeth, fissures, and incisor of chewing surfaces in the area of the tooth neck. So according to the attitude to the gums, there are 2 types of the dental plaques are distinguished: subgingival and epigingival dental plaques. The reasons for the formation of dental plaque are not known exactly. So there are some factors that play a major role in the formation of dental plaque. There are food ration, especially sugary, carbohydrate-containing foods, oral hygiene and dental care, the structure of the tooth surface, the presence of feeling, quantitative and qualitative change in oral juice and gingival fluid, and etc. So there are 3 stages in formation of the dental plaque. First, there are 4 stages. First, the penetration and fixation of microbes into the pellicle. Second one, pellicle, the formation of the extracellular matrix, extracellular organic matrix. Then increase the reproduction of microorganisms and accumulation of products of their metabolism, and finally the formation of the dental plaque. And here you see the first pellicle formation of the tooth surface, then adhesion, proliferation, and the extracellular matrix deposition by karyogenic bacteria. Due to the low pH, they induce the demineralization of the tooth, hard tissues, and finally we see with you the formation of the dental plaque. What's the pellicle? This is the unstructured homogeneous mass that covers the surface of enamel after the eruption. So there are two types of masses covering the tooth epithelium. First, we call the primary enamel cuticle, and second one pellicle. The pellicle is formed by oral juice containing amino acids and polysaccharides. Although its main function is to protect the tooth enamel from the influence of acids entering the oral cavity, on the other hand, as an optimal nutrient medium, it has created favorable conditions for the increased growth of microbes in itself and thereby becomes a dental plaque. So the microorganisms make up 70% of the dry weight of the tooth plaque. In dental plaque, there are more anaerobic mutant streptococci. One of the main metabolic properties of these microbes is that in their presence, sugar-containing carbohydrates are subjected to anaerobic fermentation that we call the anaerobic glycolysis, which leads to the deposition of a large amount of lactic acid. So the process of anaerobic irritation goes more intensively when a person is asleep at night, that is at least secreted time of oral juice. The structure of the organic matrix of the dental plaques, there are two components that include the organic matrix. First, the proteins that form from the deposits of acids in the oral cavity, and second one, the extracellular heteropolysaccharides that synthesized by microbes and contain the large amount of active carbohydrates like the glycans, dextran, levanon, etc. After the formation of an organic matrix, this mass, which contains many microbes, also includes oral juice and natural food elements. The presence of a large amount of sugar-containing carbohydrates in dental plaque, anaerobic conditions, and a decrease in the secretion of oral juice lead to process of irritation with high activity and the formation of the greater amount of organic acids. This means that the local pH on the surface of the tooth falls sharply up to 4.5 to 5 and creates optimal conditions for caries. Therefore, the dental plaque is considered one of the most important and necessary cariosogenic factors in the etiopathogenesis of caries. After a certain period of time, the tooth pulp is calcified and forms a solid consistent substrate that we call the dental stone. So the dental stone is called a solid consistent substrate, which is formed as a result of mineralization of the dental plaque, that is dystrophic or the degenerative calcinosis. For this reason, the localization of the dental stones is the same as the dental plaque. Dental plaques are more often found in epigingival or subgingival areas. Due to the frequency of occurrence and pathological significance, epigingival stones are of greater importance. Now we discuss about the morphology of the dental stone. The dental stone are formed from three layers in the transverse sections. First, the internal bacterial plaque layer without any signs of mineralization. Second, middle intermediate layer with centers of mineralization. And third, the outer surface of the tooth is completely mineralized and covered with bacterial plaque. So there are some types of the dental stones, such as the white, brown, grayish, green dental stones. All types of dental stones, regardless of their color, consistency, and the localization, are formed as a result of calcination of the dental plaque. So the dental stones are also one of the important local cariosogenic factors, such as the dental plaque. Apart from caries, the dental stones create favorable conditions for such widespread diseases as gingivitis, periodontitis, and periodontitis. The great importance of dental stones as a source of local pathogenic source, is not associated with minerals contained in them, but with a large number of microorganisms. Now let we discuss about the dental caries. Another terminology we call the rotten or the decayed teeth. The dental caries is a pathological process characterized by progressive demineralization, softening, and destruction of the hard tissues of the tooth by the formation of a defect in the form of a cavity. It is having a chronic course and is one of the most common diseases of the tooth. The most often develops in the first molar teeth, then in the second molar teeth, and then in the premolar teeth and in the incisors. The dental caries of canine teeth is less common. Most often occurs in the teeth of the upper jaw. The dental caries develops on the chewing surface, especially on fissures and incisors of the chewing surfaces, and sometimes on contact surfaces in most cases. Dental caries is rarely found on the vestibular and lingual surfaces, and it is very rare in the cervical region and at the root of the tooth. There are some theories of caries formation. Here you see the list of these theories. First, the early theories include the legend of the worm. Here you see the illustration about the early theories about the legend of the worm. Then endogenous theories that include the humoral theory and the viral theory. Then exogenous theories such as the chemical acid theory, parasitic septic theory, a chemico-parasitic or acidogenic theory, then proteolytic theory, the proteolysis chelation theory, the sucrase chelation theory, and other theories such as the sulfatase theory, autoimmune theorem, etc. The cariosogenic factors divided into two groups. First, the general cariosogenic factors, and second, local cariosogenic factors. General cariosogenic factors are types and duration of foods, food and water content, psycho-emotional stress, the general condition of the organism, and the evaluation of the stability of the internal homeostasis, age, the sexual maturity, evaluation of general metabolism, endocrine disorders, etc. But local cariosogenic factors are the dental plaque and microorganisms in it, such as the mutant streptococci, anaerobic gram-positive lactobacteria, the fusobacteria, and carbohydrates, especially food remnants with sugar contents, change in the composition and properties of saliva, such as the hyposecretion, low content of keratin protein, the raising of pH, and etc. The process of caries formation. The first, it starts by the local demineralization of the tooth enamel by irritation of carbohydrate-containing food remnants, then formation of organic acids due to action of microorganisms in the dental plaque. Second, the increasing the acidity on the tooth enamel surface. That include the increase in the number of the hydrogen ions. The pH reaches a critical level to the pH the 4.5 to 5. The melting of apatite crystals on the surface of tooth enamel, especially in the interprismatic areas, and the penetration of the organic acid into the enamel and its demineralization. Third stage is remineralization. It is the compensatory regenerative process in the enamel is more predominant and deeper. Then entering of microorganisms from gingiva to enamel and acid formation in the enamel. Fifth, the composition of fibrous structures and organic substances and formation of micro defect in the form of cones. Sixth, the releases of organic substances directly under the influence of proteolytic enzymes of microbes. Seventh, involving of dentin and dentin canaliculi to formation of tissue defect, the large conical cavity. So it was a stage of the caries formation that in the etiopathogenesis of caries, the damage of the permeability of the dental hard tissues and the pathological qualitative and quantitative change in the saliva have great importance. And here you see the illustration about the caries formation, and here you see the primary modifying factors that we discussed and the secondary modifying factors, primary modifying factors as a tooth, anatomy, saliva, biofilm, pH, use of the fluoride, diet specifics, oral hygiene, immune system, and genetic factors. And the secondary modifying factors such as the social economic status, education, lifestyle, environment, age, ethnic group, the occupation. And here you see the four factors, including the caries formation, the host, the time, fermentative carbohydrates, and cariogenic biofilm. Now, let me pass to the classification of the dental caries. There are some classification criteria for the dental caries. First, the clinical classification according to the stage of lesion progression. There are non-cavitated lesion and cavity. According to the severity of the disease, we have a classification. First, the acute caries or the active caries, chronic caries, slowly progression caries, and the stabilized caries or arrested caries. According to clinical manifestation, we can classify the caries to the white spot lesion, macular corrosia, superficial caries, medium caries, deep caries, and the secondary caries. Here is the anatomical classification of the dental caries. First, according to anatomical depth of defect, we can classify the enamel caries, dentin caries, and cementum caries. According to location of the lesion, there are 5 types of the caries: coronal caries, occlusal surfaces, smooth surfaces, approximal surfaces, and root caries. According to intensity of caries within the dentition, there are 3 types of the caries: single lesion, multiple lesions, and systemic destruction. And here is the World Health Organization classification of caries. Then there are 4 type of the caries, as you see here. First, the D1, the clinically detectable enamel lesions with intact non-cavitated surfaces. Second, D2, clinically detectable cavities limited to enamel. D3, clinically detectable cavities in dentin. And the D4, the lesions extending into the pulp. There are 4 clinical morphological stages of caries. Stage 1, the white spots. Stage 2, superficial caries. Stage 3, the middle caries, or we call the dentin decay. And stage 4, the deep caries, the involvement of pulp. And here you see the illustration for the stage of the tooth decay, the formation of the white spot, the enamel decay, the dentin decay, and the fourth stage, the involvement of the pulp, and subsequently the formation of the abscess and the loss of the tooth. The first stage is the white spot stage. Against the background of natural shiny surface of the enamel, a focus appears in a certain limited area in the form of matte spot that has lost its shine. According to its color, it's also called the chalky spot. The process is characterized by demineralization of the layer below the enamel. The reason for the external appearance of this area in the form of the spot during demineralization is the formation of microscopic cavities in the interprismatic areas and the filling of organic substances into them. Two types of spots are distinguished: white and pigmented spots. White spots are formed in the initial periods of caries and also during caries with an intensive course. Later, white spot can be turned into dark spots of different intensity, from yellowish brown to dark brown and dark color. The reasons for the appearance of pigmented spots are the fall and disintegration of various organic substances into these areas, or accumulation of tyrosine amino acid in this area and turning into melanin. Here you see the white spots in the teeth. So the pigmented spots are characteristic for relatively slow-moving caries. The transformation of white spots into pigmented spot is also considered as a temporary stabilization or slowing of the caries process. So as the spot stage caries is not accompanied by any clinical signs, the compensatory mineralization may also stop the process of caries in this spot stage. Sometimes the process progresses, the surface layer of the enamel is damaged, collapses, and the defect is formed at the enamel level. Most often, the process goes deeper into the lower layers of the enamel, reaching the enamel dentin border, and those goes to the stage of superficial caries. Superficial caries is characterized by demineralization of the tooth enamel to the enamel dentin border. Caries cover the entire thickness of the enamel layer in the spot area from the surface to the border with dentin. During caries, interprismatic areas of the tooth enamel disintegrate as a result of demineralization. Calcium salts in the enamel prisms gradually decrease. Prisms become irregular in orientation and they are completely destructed. When the interprismatic areas are destroyed, microslit and cavities are formed. So the microbes fall into these slits, multiply, and go further into the depth. In this figure, you see the superficial caries here and the caries incipiens. Superficial caries is clinically accompanied by short-term pain from the effect of various irritations, especially chemical irritations. When superficial caries has a slow course as a result of compensatory remyelinization of a new calcification zone around the defect is formed, and the defect is gradually hardened again. The process also passes to the border with dentin during a faster progression, and thus the middle caries stage begins. Middle caries is also characterized by exposure of the demineralization process and the violation to integrity of the enamel dentin boundary. At this time, the bottom of the conical caries cavity is already located on the enamel dentin border. Dentin is also exposed to injury. The dentin under the caries cavity undergoes demineralization, and the dentin canaliculi are expanded and deformed. Odontoplastic processes or the protrusions in the canaliculi are subjected to degeneration and necrosis. Microbial masses occupy their place. Under the influence of proteolytic enzymes of microbes, organic substances of dentine are released. The middle caries is characterized three areas which appear at research of cut of tools in a light microscope. The first softened dentin zone. Then this is the disintegration and the demineralization. Second, transparent dentin zone, transparent and to the intact dentin, and the tertiary or irregular dentin zone, the reparative dentin and change in pulp of tooth. And here you see the normal enamel zone. Then here you see the limiting zone, the translucent or the transparent dentin zone. Then zone where the caries lesion is in progress, we call the dark zone. Then subsurface body of the lesion and surface layer of the lesion. Here also you see the body of the lesion with the surface zone, with the translucent and the dark zone of the caries, middle caries. But the deep caries is characterized by the process of demineralization and the destruction of to the deeper layers of the dentin. Large caries cavity forms here between the pulp, and it remains a thin layer consists of damaged dentin material that we call the softened dentin. The process passes to the pulp. When this layer is pierced and penetration occurs, the pulp is directly connected with the environment. There is a short-term pain caused by effects of various irritants. Pain is eliminated when the effects of irritation are eliminated. Sometimes symptoms of pulpitis can also be found here. Now we pass to the disease of the pulp. We summarize the dental caries. Here you see the normal anatomy and histology of the pulp, and you know that the pulp is the one of the soft tissue of the tooth. Pulp builds the primary dentin during the development of the tooth, because you know the body of the odontoblast are located in the peripheral zone of the pulp. So and you know the pulp include the blood vessels and nerves, and they play a very important role in the nutrition of the tooth. But the inflammation of the pulp we call the pulpitis. It is one of the most common diseases of the tooth. In addition to the etiological factors in this development, the entire state of the tooth pulp itself, as well as the organism, has great importance. There are biological, mechanical, physical, and chemical factors that they play a role in the etiology of the pulpitis. The most important of these factors are biological factors. The pathogenic microorganisms such as the streptococci, staphylococci, which form the microflora of the oral cavity. In most cases, the infection passes directly to the pulp during deep or medium caries into the pulp through the canaliculi of the dentin, where the integrity of the flow of caries cavity is impaired, or when penetrating the thin wall of caries. At this time, inflammation, which begins as a local process of the surface layers of the crown of the pulp, can subsequently develop and spread to the apical parts of the pulp. Infection can pass through the apical hole of the tooth, sometimes during periodontitis or parodontitis, in addition to the caries cavity to the pulp, and they really through hematogenic and or the lymphogenic waste during sepsis. In addition to infectious factors, pulpitis sometimes develops under the influence of pathogenic factors of various mechanical, physical, or chemical nature. For example, effects of mechanical, especially thermal factors on the pulp in treatment of the caries cavity, or toxic effect of chemical, especially acids, ethers, medicines, thymol, and other filling materials on the pulp tissue. So we can call these diseases such as the iatrogenic diseases. The mechanism of development of pulpitis is the same as in all inflammatory process. However, due to the small and relative close environment of the pulp, the pathogenesis of pulpitis is also characterized by some specific features. The process begins with the alterative effects of the pathogenic etiological factor on the pulp. Initially, the enzymatic change occurs at the biochemical level, which are accompanied by corresponding fractional disorders of the pulp, increased vascular permeability of the pulp in the exudation phase of inflammation, venous stagnation, migration and increasing proliferation of inflammatory cell elements, stasis, and edema occurs here. This inflammatory exudate, which initially has a serous nature, can subsequently pass into purulent exudate. So here is the not serous, this is the serous, this is mistakenly. So we call the serous pulpitis and the purulent pulpitis after 6 to 8 hours later. Due to the fact that the root canals of the tooth are narrow, the apical hole is relatively narrow. The process of elimination of tissue fluid and exudate formed in the pulp is complicated. This causes an increase in edema and exudate fluid in the pulp, which is considered a closed cavity, and the pressure inside the pulp rises. In addition to the effect of bioactive amines formed due to inflammation, acute irritation of the nerves in the pulp due to the mechanical effects of increased pressure causes pain. Necrosis of the pulp may occur as a result of a strong alterative effect of the pre-pathogenic factor or as a result of subsequent deepening of dystrophic or degenerative, exudative, and proliferative inflammatory processes. At this time, acute necrotic or gangrenous pulpitis develops. Now, let me classify the pulpitis. There are two types of the pulpitis for the clinical course: the acute pulpitis and chronic pulpitis. Acute pulpitis is subdivided also the acute focal pulpitis with the focal serous pulpitis, focal purulent pulpitis or abscess, and acute diffuse pulpitis with the diffuse purulent pulpitis, phlegmon, and diffuse gangrenous pulpitis. And the chronic pulpitis subdivided to the gangrenous pulpitis, hypertrophic pulpitis, or the granular pulpitis, polyposis, and fibrosis. Acute pulpitis usually begins locally in the form of inflammation of serous nature near the cavity of the caries and then spread diffusely. The total duration of acute pulpitis usually lasts no more than 2 weeks. After this time, the acute pulpitis passes into chronic pulpitis. Clinical symptoms of acute pulpitis include presence of spontaneous convulsive pain without the effects of external irritation. Pains are convulsive, that's periodic, intermittent. This feature also occurs in acute phases of chronic pulpitis. Long-term pain caused by all external irritation, even with pure strain. During caries, however, the pain occurs to the action of strong irritation, and the effect of irritation is also stopped as it is removed. At night, the intensity of pain increases during acute pulpitis due to greater activity of the parasympathetic nervous system as well as the exacerbation of chronic pulpitis. Acute focal pulpitis is the initial stage of inflammation of the pulp, beginning immediately in the contact area of caries cavity. First, the serous pulpitis develops in that area. Acute hyperemia, edema, small diapedesis, hemorrhage, and individual single foci of leukocytic infiltration occur in microcirculatory vessels. A serous exudate in the form of small foci is formed in this part. In most cases, acute focal pulpitis develops in the crown part of the pulp. Serous pulpitis begins a few hours, about 6 hours after the neutrophil's migration due to inflammatory process change its character and passes to focal purulent pulpitis. Acute, in the part of the pulp, which is the contact with the caries cavity, a focal focus of pus abscess is formed. The exudate contains a large number of active macrophage and plasma cells. There are also a fragmentation of the nerve fibers and the deformation of myelin sheath occurs. Odontoblasts in this area are separated and irregular in the orientation due to edema. The degenerative and the destructive change in their cytoplasm are detected. This is the figure of the acute pulpitis, and we see with you the acute pulpitis with intrapulpal abscess formation. The pain is in the damaged dental area. It doesn't irritate, lasts from 10 minutes to 1 hour, and there are several hours intervals between the seizures. No facial change are detected in the visual inspection. After 1-2 days, the acute pulpitis passes into diffuse pulpitis. Acute diffuse pulpitis occurs as a result of spreading of the focal inflammatory process to the roots of the pulp. So exudate mainly consists of diffusely spreading pus. Develops the purulent diffuse pulpitis or the phlegmon of the pulp. It is the most common form of all pulpitis. All microscopic pathomorphological change observed along the pulp are similar to those in the inflammation site during the focal pulpitis. All structural elements of the pulp, including the nerves, are damaged and undergo irreversible destructive change. For this reason, unlike focal pulpitis, clinical signs of pulpitis are also changed. The duration of pain attack prolonged. Intervals between attacks are reduced to 10-30 minutes. Pain irritates along the branch of the trigeminal nerve. If the pulp cavity is directly connected with the caries cavity, so the penetration of the caries cavity and anaerobic microorganisms fall into pulp, necrosis and gangrene of the pulp occurs. This is called diffuse gangrenous pulpitis. At this time, the pulp becomes an unstructured mass. Now let me discuss about the chronic pulpitis. The chronic pulpitis develops freely after about 2 weeks as a result of long-term effects of low-intensity pathogenic factors or as a subsequent of acute pulpitis that is not adequately treated. The duration of chronic pulpitis is from several weeks to several months or even years. Chronic pulpitis sometimes occurs as a result of penetration of the caries wall during acute pulpitis and the direct contact of the pulp with the caries cavity. Chronic pulpitis is 2 times more common in practice than acute pulpitis. The stage of chronic pulpitis. First stage, the new connective tissue, the granulation tissue, is gradually formed around the local foci of pus, the abscess, or in the area of diffuse inflammation. Granulation tissue is infiltrated by lymphohistiocytic elements containing a large amount of dilated thin-walled capillaries. Therefore, it is prone to bleeding under the influence of the most common mechanical factors. Second stage, the inflammatory infiltration of the pulp weakens, the number of collagen fibers and fibroblasts decreases, and granulation tissue gradually turns into a coarse, fibrous, connective tissue. The pulp is sclerosed, prone to calcinosis, but periodically absorbed with exacerbations. The clinical symptoms of chronic pulpitis. The course of the disease for a long time, months, even years. Pure subjective symptoms, for example, a feeling of pain in patients despite large volumes of deep or medium caries. The presence of long-term pain from the effect of external irritants factors, unlike caries. There is pain during eating, chewing, and sometimes bleeding from the pulp, and etc. So, exacerbation of chronic pulpitis, the psycho-emotional nervous tension, filling of the caries cavity with compressed food residues, other mechanical effects, excessive fatigue of the body, common cold, infectious disease, and etc. Chronic gangrenous pulpitis. Chronic gangrenous pulpitis occurs as a result of necrosis of a part of the pulp against the background of acute pulpitis. At this time, under the necrotic part, the granulation tissue separated the necrotic mass from the non-necrotic part of the pulp develops, and the process becomes chronic. There are 3 parts of the pulp during chronic gangrenous pulpitis. First, outer parts, the dead gangrenous or necrotic mass, rich in microbes. It is located directly in the part that opens into the caries cavity. Second, middle part, that infiltrated granulation tissue, also plays the role of a demarcation zone. And inner part, the serous or purulent pulp and or undamaged pulp, it is located under the granulation tissue. Chronic gangrenous pulpitis is sometimes exacerbated or progressed to total gangrene of the pulp. Chronic hypertrophic or the hyperplastic pulpitis or the chronic granular pulpitis. Most often, it is formed as a result of acute purulent and sometimes as a result of acute diffuse pulpitis. Due to the action of numerous and prolonged external irritations through the caries cavity, a large amount of granulation tissue is formed in the pulp and is characterized by signs of proliferative or the productive inflammation. It is consistently soft, reddish in color, fragment and easily bleeding, occurs due to the influence of external mechanical factors. If this granulation tissue in the pulp is associated with the gingival epithelium from the caries cavity, the gingival epithelium increases and multiples, covering the granular tissue in the form of stratified squamous epithelium, and here forms the polyp in the caries cavity that we call the pulp polyp. This granulation tissue in the pulp matures and eventually turns into a rough fibrous connective tissue, resulting in complete sclerosis of the pulp that we call the chronic fibrous pulpitis. In this figure, we see the gross view of the chronic hypertrophic or hyperplastic pulpitis. Here is the tissue of the pulp, the adjacent caries, tools, and you see the granulation tissue that covered with the stratified squamous epithelium. And this is the pulp polyp or the chronic hyperplastic pulpitis. Another illustration, what we see here, the dentin zones in the adjacent tissues, and in the middle side is the chronic inflammatory cells and the granulation tissue with the current stratified epithelium and the high power of the pulp polyp. And we see with you the stratified epithelium and the inflammatory infiltration in the connective tissue of the pulp. Chronic fibrous pulpitis is characterized by the replacement of the pulp with coarse fibrous connective tissue that rich in a large number of collagen fibers, the formation of the sclerosis, in the background of proliferative inflammation, the formation of the granulation tissue. It usually occurs as a result of all chronic pulpitis. During the histological examination, we found the signs of the productive inflammation, such as the lymphocytic infiltration, the plasma cells, macrophages, the small hyalinosis or calcinosis among the elements of raw fibrous connective tissue. Clinically, it is accompanied by paroxysmal pain caused by various external irritations. Now, let we discuss about the periodontitis. Periodontitis is called inflammation of the periodontium. It is considered one of the most common diseases of the tooth. The periodontitis of infections origin is more common and therefore of greater clinical and practical importance. Periodontitis is most often caused by streptococci. The role of other microorganisms is very small. The infection can pass off the periodontium by two ways, by the intradental and extradental ways. Intradental infection of the periodontium occurs mainly during pulpitis, as its aggravation is more common. The probability of occurrence of extradental infection is relatively low. Periodontitis it can occur either by the hematogenous and lymphogenic way during infectious disease or by the contact way during the inflammation of the surrounding tissues. The traumatic periodontitis occur after single mechanical influence, such as acute, acute traumas as a blow to the tooth, crash, bite of a solid object after multiple repeated micro traumas when the compensatory adaptation mechanism of the periodontium are depleted. But the medicamentouse periodontitis usually occurs as a result of improper use of medicinal preparations or strong acting reagents during the conservative treatment of dental diseases, especially pulpitis. For example, arsenic preparations, formalin, antipyretics, filling material, and etc. Classification of periodontitis is carried off according to his clinical course, such as acute, chronic, pathological anatomical characteristics, and the nature of the inflammatory process, as well as its localization. Apical periodontitis also subdivides to acute apical and chronic apical periodontitis. So the acute apical periodontitis has also two types: the acute serous periodontitis with the local diffuse types, and acute purulent periodontitis with the local such as abscess and diffuse purulent infiltration. Chronic apical periodontitis, divided into three types: the granulating periodontitis, granulomatous periodontitis or granuloma, and fibrous periodontitis. And second types of the periodontitis is marginal periodontitis, that located in the gum region. Acute apical periodontitis is localized at the apex of the tooth. It develops rapidly and has a progressive clinical course. The pain cessation is localized and permanent, while the inflammatory process is common. The pain cessation is also irritated along the branches of the trigeminal nerve. The duration of the process lasts from 2-3 days to 2 weeks. After that, the acute apical periodontitis either recovers or becomes chronic. Dependent on the nature of inflammation, two types of acute apical periodontitis are distinguished. First, acute serous periodontitis, and second, acute purulent periodontitis. Acute serous apical periodontitis, local periodontitis, which first develops acutely as serous exudative inflammation, is then able to pass into the local purulent periodontitis in a short time, dependent on the general immune state of the microorganism and other factors effects. During serous periodontitis, hyperemia, edema, infiltration of individual lymphohistiocytic elements occur in the apical part. Clinically, this is accompanied by local and constant, weak intensity local pain. Gradually, the neutrophil intensity rises and the inflammatory process becomes purulent. Purulent inflammation is sometimes localized in a limited area. Under the influence of proteolytic enzymes, the tissue becomes purulent and abscess form, acute focal purulent periodontitis. Sometimes the purulent process goes beyond the apex of the teeth and spreads throughout the periodontium and gum. Acute diffuse purulent periodontitis or purulent infiltration of the periodontium develops. Purulent inflammation is sometimes localized in a limited area under the influence of proteolytic enzymes. Sometimes in acute diffuse, it's a summary of I have that I explained just in acute diffuse purulent periodontitis as a reactive perifocal process. It can develop acute edema and serous diffuse inflammation in the jawbones and the nearby soft tissues. This is called the flux or the Periodontitis. And here we see we do the acute apical periodontitis. So first the extraoral swelling in the left cheek region, then intraoral vestibular swelling associated with the severely broken down first premolar, and the X-ray examination of the apically position radiolucent area. So chronic apical periodontitis is a chronic inflammation of the gum at the apex of the tooth. The main pathomorphological feature is a productive proliferative tissue change in the focus of inflammation and the development of the connective tissue or sclerosis. Clinical signs include the relatively very weak, sometimes even absent, and in some cases, chronic periodontitis accompanied by a weakening of the immune system of the body is periodically exacerbated. As we mentioned earlier, there are three types of the periodontitis: the granulating periodontitis, granulomatous periodontitis, and fibrous granuloma. Chronic granulating periodontitis usually develops after acute purulent periodontitis. In the root zone periodontium, a weak lymphocytic infiltration with granulation tissue, neutrophil mixture, rich fullness capillaries are detected, or the rich hyperemic capillaries. So this form is more often aggravates than other chronic periodontitis. In the period of exacerbation, the intensity of this lymphocytic infiltration, such as the purulin exudate with the neutrophil mixture, increases, and sometimes even flows through the waste formed under the gum. The X-ray examination show, in addition to granulation tissue, destructive change, osteoclasia or osteoclasia with inaccurate contours that can be detected at the apex of the tooth, as well as the bone alveoli in this area. Here we see we do the chronic granulating periodontitis before treatment and after the treatment, that we see the recovering of this lesion. Chronic granular periodontitis or granuloma, most often found in the large and small molars of the upper jaw and sometimes in the lower jaw. The capsule consists of rough fibrous connective tissue around the granulation tissue, and the apical zone also formed here. This fibrous tissue covering the granulation tissue from inside is adjacent to the surrounding solid tissues, the bone alveoli, the tooth root, which is partially destroyed from the outside. Chronic granular periodontitis, also so-called as a simple granuloma or non-epithelial granuloma. It is characterized by a weak infiltration of inflammatory cell elements, in addition to the connective tissue of young and rough fibrous connective tissue. In the phase of exacerbation, the intensity of infiltration increases, and a large number of neutrophils are also formed here, and the chronic foci of inflammation become purulent. Here is a figure that demonstrates the histological structure of the chronic granular periodontitis. Here we see the granulomatous lesion of chronic apical periodontitis with epithelial strands, and also the histological illustration, the morphology of the chronic granular periodontitis. Another type of chronic granulomatous periodontitis is called the compound granuloma or epithelial granuloma. It is more common than simple granuloma. In contrast, in a granuloma, there are squamous stratified epithelium areas here. These epithelial strands also enter into the granulation tissue. These epithelial cells, when the complex granulomas occur, take their origin from the embryonic odontogenic residual epithelium that we call the epithelial res of Malassez in the periodontium. In these histologic figures, we see we do the epithelial strands in the periapical granuloma. So the epithelial cell masses that originated from the epithelial res of Malassez proliferate in the periapical granulomas and from strands. And here you see this longitudinally and the perpendicular sections of this epithelial res of the Malassez. And under the higher magnification, we see the formation of the epithelial strands. Under the high magnification, you can found the histological or cellular content of the periapical granuloma, such as the lymphocytes, the macrophages, and the connective tissue elements, as well as the neutrophils we found inside of the periapical granuloma. Cystic granuloma or the periapical granuloma, it's called after the certain period of time, the compound granuloma turns into a cavity, the formation of the cyst to the necrosis and purulent formation of granulation tissue. So the wall of the cyst, which has solid contents, eosinophilic exudate, cholesterol crystals, is covered with fibrous tissue from the outside and with the epithelial layer from the inside. So properly treated cystic granulomas pass into fibrous granulomas, these types of chronic periodontitis. In the absence of proper treatment, cystic granulomas turn into radical cysts of the jaw. So here is the histopathology of the periapical cyst with metaplastic change of mucous secreting cells and ciliated cells. Under the high power, we see here the mucous secreted cells like the goblet cells and the metaplasia of the ciliated epithelium. And here you see the cholesterol cliffs in the periapical cyst of the jaw. Clinically, the chronic granulomatous periodontitis is not accompanied by any subjective or objective symptoms during remission. Under the radiologic examination, an oval shaped focus with precise contours in the form of an intensive shadow of about 0.5 to 0.8 centimeter in diameter appears. Here you see the CT computer tomography scan probe head showing the right periapical cyst, and here you see the dental cyst eroding the anterior wall of the maxilla. Fibrous periodontitis, the final stage of the development of all chronic periodontitis. So granulating periodontitis can pass into this form both directly and through granulomatous periodontitis. At this time, the granulation tissue around the tooth root gradually turns into a rough fibrous connective tissue. The fibrous tissue, the number of inflammatory cell elements is further reduced. Fibrous periodontitis is very rarely exacerbated. During the period of remission, there are no clinical signs. X-ray examination determines the expansion and deformation of the periodontitis cavity in the tooth root area. In the nearby contact solid tissues, usually no change are noted. Here is the histology of the chronic periodontitis with the proliferation of the connective tissue fibers, collagen fibers, and fibroblasts in the chorion. The staining with the maston trichrome. So we finished our lecture, and most of the material taken from the textbook of our head of the department, Professor Hasanov. Thank you very much for your attention.